بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلاب وطالبات المستوى الرابع، برنامج بكالوريوس طب جراحة الفم والأسنان. أهلا وسهلا ومرحبا بكم في مستهل اللقاء السابع ضمن لقاءاتنا التعليمية في مقرر طب الفم. في هذا اللقاء سنبدأ الحديث عن lesions, the oral lesions, starting with the variance of normal. What is the lesions which is a normal variance, and what are the common benign conditions? In this lecture, the references of this lecture will the Handbook of Oral Medicine in addition to Burkett's Oral Medicine. The aims of this lecture, the student at the end of this lecture should be able to recognize the normal variance lesions as well as how to differentiate them from the other serious clinical findings, and the students should be able to diagnose and manage the common benign conditions. We will talk about some of the common benign conditions and variations of normals in these lectures, starting from physiological melanin pigmentation and Fordyce granules, gingival grafts, lingual tonsils, geographic tongue, medial-rhomboid glossitis, fibroma as a common benign condition, and also the tori and ankylosing. All these common benign conditions and normal variations, we will talk about each one in detail throughout this lecture. First one is the physiological melanin pigmentation or physiological pigmentation. As we know, in the histopathology and the histology, we have epithelial cell layer and also then the connective tissue. This is the basement membrane. At the basement membrane, we have a basal cell layer, and then we have the superficial layers of the epithelium as we studied in the histology. This is the epithelium and this is the connective tissue. At the basal cell layer, at this layer, some type of cells are called melanocytes. Melanocytes are a physiologically presented cells, normally presented cells in the basal cell layer, of the oral epithelium, and it secretes a melanin. This melanin is a physiological pigment, so can be presented as a melanotic macules or a physiological melanin pigmentation due to over secretion of the melanin by melanocyte. Clinically can be presented as light brown or black discoloration in the skin or the oral mucosa. Physiological melanin pigmentation, as we mentioned above, due to production of melanin from the melanocytes mentioned. The physiological melanin pigmentation clinically also presented as a focal freckle-like melanotic macules, as we see in the pictures. This is the very common appearance of this lesion. The keratinized mucosa, in particular the gingiva, is the most common affected site. As we see in this clinical picture, the gingiva is affected by physiological melanin pigmentation. This is the black or dark brown discoloration on the attached gingiva. Pigmentation also is due to deposition of melanin into the connective tissue without increase in the cell number or size of the melanocytes. So the main cause is the over-secretion, increase in the secretion of the melanin by melanocyte without increase in the cell size or the cell number of the melanocytes. This may become more pronounced areas in the chronic traumatic areas and areas of chronic inflammation, such as along the occlusal bite line on the buccal mucosa. As we see in this picture, this is the chronic inflammation site. After resolution of the resolving of the problem, this will be apparent as a physiological melanin pigmentation due to chronic cheek biting in the buccal mucosa. After we remove the cause of the chronic cheek biting, the lesion persists as a physiological melanin pigmentation. So the diagnosis can be made clinically according to the history and the clinical presentation. Biopsy is warranted to rule out melanoma. The most important differential diagnosis of the pigmentation in the oral cavity is the melanoma, which is a malignant lesion. This malignant lesion arises from the melanocyte, melanocytes, and it is some serious lesion treated as a cancer. And the melanoma most commonly presented in the skin. Physiological melanin pigmentation, if any changes are noted in the size or the shape or the degree of pigmentation, or if a flat lesion become raised. So the pigmentation, as we see in the last pictures, it is flat macules, as we mentioned in the clinical description of the lesions. There is a macules or patches, which are both flat, non-raised lesions. If these lesions become raised, so the biopsy should be done to rule out any other serious lesions such as the melanoma, as we mentioned. Intraoral melanoma, however, is exceedingly rare. As we mentioned before, melanoma is a skin lesion most commonly, but there is a rare presentation in the oral cavity or in the oral mucosal lesions, and it's about less than 1% of all melanomas. This is the intraoral melanoma. Other causes of pigmentation including both intrinsic and extrinsic etiologies. So we have to differentiate the physiological melanin pigmentation from other causes of pigmentations, either intrinsic or extrinsic source. In this case, complaining from widespread pigmentation in the oral cavity, especially in the tongue. This is female from Al-Hudaydah Governorate, complaining from pigmentation in the skin and also in the oral mucosa. This case finally was diagnosed as Addison's disease due to the widespread pigmentation between the skin and the oral mucosa, and the patient complaining from other symptoms regarding the Addison diseases. So we differentiate it from the physiological melanin pigmentation. This case is also complaining from physiological melanin pigmentation on the attached gingiva. This case was treated by surgical scrubbing of gingiva, removing the superficial layer of pigmented tissue, and this is the other case with pigmentation, and this is after 3 days of gingival scrubbing, which is the surgical removal of the pigmented tissue. The treatment of physiological melanin pigmentation is the surgical removal. Surgical removal can be surgically by the surgical blade and anesthesia and surgical blade, and also we perform the surgical removal by scrubbing or stripping the gingiva. Other methods can be used is the laser removal of the pigmented tissue, or by using rotary instruments like the hand bees with diamond bears. The other normal variations are the Fordyce granules. Fordyce granules are a specious gland ectopically presented in the oral mucosa. So it is normally presented in the skin, but it is a normal tissue, what we call it ectopical presentation, normal tissue in abnormal site. So this is a normal tissue, specious gland presented in abnormal site, buccal mucosa, due to the proximity of the skin to the oral mucosa in this area. There are less commonly noted in the lip or the labial mucosa. So clinically is presented as a white, yellowish color, generally presented in the as a clusters in the buccal mucosa, the most common site, may be slightly raised, and it is also asymptomatic, so the patient doesn't complain from any other symptoms. Specious gland in the oral mucosa are non-functional, but it is functional if it is presented in its normal site, the skin. Clinical appearance is usually classic and sufficient for diagnosis, so we don't have to had a biopsy. Gingival grafts are one also of the normal variants. In cases of severe gingival recession, gingival grafting is performed as a periodontal surgical procedure to restore the attached tissue. The donor site, which is harvested from the patient's palate as an autograft, is raised and also more pale than the adjacent gingiva. This is the skin graft or the gingival graft. In the case of gingival recession, when the teeth has a receded gums, so there is a gingival recession, there is an exposure of the tooth root, so we need to cover this area. One of the surgical procedures is to take a donor tissue from the patient's palate and put this tissue sutured in this area. After the healing, this area appeared as a skin or gingival graft, as we see in these pictures. These cases was complaining from less attached tissue in this area, so we had a autograft from the patient's palate and sutured it at the site of implants where there is no attached gingiva, and after 2 weeks of healing, this is the final appearance. So this case is treated in reality with increased attached gingiva, but clinically it appears as a gingival graft, so we should differentiate it from other serious lesions. This is the graft which was taken from the patient's palate, and this is the other case which is the site of the donor tissue, the donor site of the tissue, and this is after suturing after the operation. These cases, 2 cases, are treated by us to resolve the recession problem. This is the tooth and also this tooth with severe gingival recession. Lingual tonsils, also one of the normal variants of the tissue. As we know, the lymphoid tissue is often found along the posterior lateral tongue, forming part of Wilder ring. Wilder ring is a pharyngeal lymphoid ring, also we called it a pharyngeal lymphoid ring. Lingual tonsils appears as exophytic mucosal colored masses, exophytic, so it is raised, and that may exhibit folds and cryptus as seen in the palatine tonsils. The lingual tonsils, as we see in this figure, are presented at the posterior part of the tongue. This is the epiglottis, this is the foramen cecum, and this is the circumvallate papillae, which are presented as a V-shaped papillae. This is the palatine tonsils and this is the lingual tonsils. Their clinical presentation might be strikingly prominent, unilateral or asymmetrically enlarged tissue should be considered for biopsy to rule out other pathology such as lymphoma and also the squamous cell carcinoma. So when these lingual tonsils are hypertrophied or prominently apparent bilaterally, so it's okay, it's a normal variance. But if it is a unilaterally prominent tissue, should be considered for biopsy to rule out other serious lesions. Fissure tongue, or what we called it scrotal tongue, is the presence of fissures and grooves along the dorsal surface of the tongue. These can range from shallow appearing cracks to deep grooves and penetrating fissures. Most patients are universally asymptomatic, so they haven't any complaint or any symptoms. This can range from shallow appearing cracks, as we mentioned above, to deep penetrating grooves. The fissure tongue, there is a remarkable variation in the appearance of the tongue throughout the population. So somewhat there is a medial crack or medial fissure, and in some cases, in some patients, there is a horizontal laterally presented fissures. It is uncommon for a patient to examine his or her tongue and become aware of the presence of fissuring following the onset of the otherwise unrelated symptoms such as burning mouth syndrome. Might be there is an association with burning mouth syndrome with the fissured tongue, and this is the most common complaint or symptom if there is symptoms. Geographic tongue, also referred as a benign migratory glossitis, benign because this lesion is a benign condition. Migratory because the lesion started from one side on the dorsal surface of the tongue, and the lesion migrated, transmitted to other side and other side. So it is a migratory in nature. Glossitis, due to the inflammation of the geographic tongue lesion, is a common inflammatory condition of the tongue and also evident in early childhood and rarely causes symptoms. The geographic tongue clinically presented as irregular shaped erythematous macules. These are the erythematous macules, the areas of depapillation. So the papillary nature of the dorsal surface of the tongue is absent, surrounded by elevated white borders and patchy areas of depapillation and smooth glossy mucosa. Smooth glossy mucosa due to the depapillated areas. These areas are depapillated, and these are the white borders, elevated white borders. These areas transmitted or migrated from one side to another during the time. There are another conditions that mimic geographic tongue, including the oral lichen planus should be differentiated from it, and also erythematous candidiasis as well as the leukoplakia. Patients may describe sensitivity of the tongue to otherwise normally tolerated food and beverage. Management with topical therapies may be effective in such cases. So the most common dental management is topical therapies. We'll talk about it. Importantly, other causes of tongue sensitivity must be considered, such as candidiasis and immune-related conditions. Diagnosis based on the clinical appearance, as we see the depapillated areas and borders, which is white in color and raised, and the migratory appearance of the lesion. Treatment of symptomatic cases: rinse containing topical dexamethasone to reduce the burning sensation, or we can use the diphenhydramine, which is the first generation of antihistamines, may be as effective in reducing these symptoms. So dexamethasone as a corticosteroid and diphenhydramine as a antihistamine. Other causes of tongue discomfort such as burning mouth syndrome should be also considered. Medial rhomboid glossitis. Medial rhomboid glossitis is also one of the normal variants lesion, which is chronic atrophic erythematous depapillated patches in the posterior midline of the tongue dorsum. This is the site of the median rhomboid glossitis. Median, due to its the presence in the medial surface of the dorsal surface of the tongue. Mild discomfort may develop especially in the area of atrophic tongue. The medial rhomboid glossitis, in these cases we can use a tissue biopsy which will demonstrate a superficial candidal colonizations. So the research presented or reported the presence of candidal infection at the site of medial rhomboid glossitis, and the textbooks reported that the main cause or the main etiology is the candidal infection. And also in the histopathology we will see an inflammatory infiltration of the cells in the underlying connective tissue. First line treatment so is topical or systemic antifungal therapy such as nystatin. It can be presented or provided as a drops. If symptoms persist, topical corticosteroid therapy should be started. Fibroma, probably the most commonly encountered oral soft tissue lesion. This is one of the common benign conditions. Frequently used terms include irritation fibroma and traumatic fibroma due to the main causes of fibroma, irritation and traumatic, initiated by trauma or secondary to friction from sharp edge of tooth, as well as dental restorations if it is mal-structured or mal-restored tooth. This is the clinical cases or the clinical appearance of fibroma. Fibroma present clinically as a round or ovoid, firm, exophytic, smooth surface masses. It has the same color as or slightly lighter than the surrounding tissue. This is the clinical case of fibroma also. Slightly lighter than the surrounding tissue in color, and it has a smooth surface. The treatment of fibroma is surgical removal. Inflammatory papillary hyperplasia, it is a benign reactive condition that develops on the denture bearing mucosa. Focal lesion which a distinct wrinkled or folded appearance is often termed ebulus fissuratum. This lesion is usually associated with malformed or patient with malformed restoration prosthesis, or patient with bad oral hygiene and he has a restoration or prosthesis, complete denture or partial denture or whatever. Lesions are characterized by bubbly papillary changes, so its name is a papillary. So this is a papillae under the complete denture. This picture of the upper complete denture. This is a papillary exophytic lesions or hyperplastic lesions that variably associate with the tissue hyperplasia and verrucous like changes. it is thought the chronic irritation due to the loose or poorly fitting denture, as we mentioned above, or inadequate denture hygiene. So the bad oral hygiene also in the patients with complete or partial denture may lead to inflammatory papillary hyperplasia on the denture bearing areas. Also, the cause might be a candidal colonizing under the denture material, contributes to localized inflammatory mediated reactive changes in the oral mucosa, as well as mimic other pathological conditions including proliferative verrucous leukoplakia. This is the differential diagnosis of inflammatory papillary hyperplasia, and also the squamous cell carcinoma may be presented in the same clinical pictures as inflammatory papillary hyperplasia. So biopsy may be needed to exclude any dysplastic changes or malignancy transformation of this lesion. The management of inflammatory papillary hyperplasia should be started with the prosthesis, which should be evaluated for fitting, stability and hygiene. Hyperplastic tissue can be also surgically removed by laser or by surgical removal. The other lesion is the tori and exostosis. Tori and exostosis are bony lesions that can be presented in the maxillary arch or the mandibular arch. These are benign developmental bony growth that are commonly observed in the oral cavity. Similar lesions that may be presented in the buccal aspect of the maxilla or the mandible, we called it a bony exostosis. So we have a tori, palatine tori, and we called it a torus palatinus, and also we have an exostosis, exostosis. The tori are presented in the lingual for the lower and the palatal for the upper arch, but the exostosis presented in the buccal or labial aspects of the upper or the lower arch. These are covered by keratinized, as we see in this picture, by keratinized mucosa depending on the anatomical location. Maxillary tori most commonly presented in the midline of the hard palate as dome-shaped, smooth swelling, multilobulated masses, as we see in the last picture. The mandibular tori also developed most commonly along the lingual aspect of the mandible, inferior to the premolar area bilaterally. This is corresponding to the premolar tooth, bilaterally presented mandibular tori. The management of tori and exostosis should, in general, should not require any treatment, but if there is an ulceration in the covering mucosa but if there is an ulceration of the covering mucosa which become irritated and ulcerated secondary to chronic trauma, and also due to the thinning of the mucosa under the bony exostosis or bony tori, should be managed symptomatically. And also the bony exostosis can be treated surgically. This patient complaining from bony exostosis presented in the buccal mucosa of the upper arch, flap was done, and also the osteotomy to remove the bony exostosis in this area has been performed. Ankylosing or prominent frenulum. Frenula, as we know in the oral diagnosis, is a tissue attachment of the anterior tongue and labial mucosa. Ankylosing lead to problems with speech development or infant feeding. If the tongue is attached to the floor of the mouth, by this highly frenal attachment, can lead to problems in speech and feeding of the infant. Also, there might be a periodontal recession due to attachment of the labial or lingual mucosa in the associated teeth. The prominent labial mandibular frenum similar affect the facial aspect of the same teeth. High insertion of the maxillary frenum onto the gingiva may lead to formation of the gap or diastema between the two central incisors, as we see in this case. This case of the patient, young adult patient complaining from high frenal attachment in the labial area and the frenal attached nearly to the base of the interdental papilla between the two central incisors, leading to the diastema. So it is treated by surgical removal. Surgery also is indicated, as we mentioned. In conclusion of this lectures, which we're talking about variations of normals and the common benign conditions, we talk about the physiological melanin pigmentation and Fordyce granules and gingival graft, and also we're talking about lingual tonsils, geographic tongue, medial rhomboid glossitis, and the fibroma and the surgical management of those three lesions, the fibroma, tori, and also the ankylosing. The assignment of these lectures is a case presentation. Each student or group of students ranked from 1 student to 5 students, 1 to 5 students. Each group should present a case of one of the common benign conditions and normals from variations that mentioned in this lecture, and this assignment will be explained in the assignment section under the number of the assignment 7, the number of the present lecture, as an attached Word document in the LMS website. Thank you, dear students, for your listening.